doing a blood gas and how to interpret a blood gas analysis. Okay, so Dr. Prashant, you did a good job, but try to focus on what common questions that people usually ask in exams,
Yes,
and only about basic care of extreme preterm babies. Right?
yes,
You can stop
thank you.
your video.
Thank you, sir.
So in this next few, what usually happens, like when I ask my residents how a blood gas is interpreted, is by taking a picture of the blood gas and posting it on our group or sending it as a WhatsApp message like this. So, and most of the time we'll end up in answering the questions. Okay, there is acidosis. So what happened? Increase this, decrease this. So this is what happens in usual NICU settings. No, that's not the way we are supposed to interpret a blood gas. And today I'm going to just walk you through of what are the simple steps in interpreting a blood gas analysis. So this is going to be practical. There is no theory, and I'll probably show you an algorithmic approach. I will not talk about the chemistry of blood gas, that is a Henderson-Hasselbalch or acid-base balance, buffering systems. What are the different organ systems doing? Or different methods of, there are different methods like Boston method, Copenhagen method, and Stewart method. We still don't know which is the best method, but what we are conventionally following is what I will be talking to you in the next 20-25 minutes. Okay, so there are three considerations that you need to give before you interpret any blood gas. So these blood gases are pre-analytical stage, where which sample and what is the patient status, how have you collected, and what is the time of sending to the lab, or if you have a blood gas machine. The analytical phase, where it depends on the machine itself, and the turnaround time. So the sampling sites usually are arterial, which is the best. That's why it's called the arterial blood gas. If you cannot do an arterial sample, then the next best would be arterialized capillary blood gas. The least preferred is the venous blood gas. So if you have done a venous blood gas, it's as good as not useful or useless. So, but in the arterial blood gas, what you should know is that you should not be doing a stab sample. By poking the baby with a needle, you are causing a lot of pain, crying, a lot of CO2 washout. Your blood gas interpretation will go for a toss. So don't do a stab sample. Preferably, if you have an indwelling catheter, either umbilical or radial, that is the most accurate measurement of the baby's physiological status at that moment. Arterialized capillary is a good way when we heat the heel and take a sample by usually a lancet. It does not cause so much pain, doesn't cause so much of problems. But it's not a very good indicator of PO2, especially when peripheral perfusion is poor. That's the only drawback of an arterialized capillary sample. So pre-analytically, we can have a lot of errors. That is, if you put on heparin, it can cause a lot of errors if you don't take out the excess heparin from the syringe. Secondly, if you have air bubbles, it can cause ABG to be erratic. Temperature, I'll tell you how to minimize all of these. If the baby is having hemolysis or leukocytosis, it can interfere with the interpretation of blood gas. And if you want an arterial blood gas and you somehow poke the vein, you will have misinterpreting signs there. Okay, so if you have air, because air has very less of carbon dioxide, the CO2 from the blood will get diffused to the air. So the CO2 drastically comes down in the sample. PO2 increases because of oxygen in the air. So thereby pH can increase because PCO2 is falling down. The opposite thing happens when you mix venous blood, that PO2 goes down because veins have less PO2. PCO2 goes high, pH comes down. Excess heparin, because it's an acid, It can cause false elevation of pH, and also it can reduce the PO2 in the sample. If the patient is agitated, it will obviously wash out PO2. So how do you measure this? Per hour, if you delay your sample analysis, pH will reduce by 0.05. PCO2 will increase because the RBCs are metabolizing and they're producing CO2. They increase by 5 mmHg, and PO2 can reduce. So these are the few things you need to remember in the pre-analytical phase. So there is some medical legal implication of doing a blood gas. If you do a blood gas and unfortunately you end up in causing gangrene of the hand, you are responsible if you have not done the modified Allen's test. So I'm sure all of you have heard of modified Allen's test, but somehow it has not come into routine clinical practice. Wherever I ask students, residents who are doing blood gases are actually telling me that they don't usually do Allen's test. I'll show you how to do an Allen's test, and I already told you the implication of that. You should take the appropriate syringe, preferably pre-heparinized syringes which are available. And if you're using heparin, additionally, you should use the low concentration like 1000 international units per ml. And whatever air is there should be expelled, and it should be processed definitely within 30 minutes. If you have a bedside blood gas analyzer, it's the best. If you don't have and you need to send to the lab, transport in ice packing, and maximum time we can allow a blood gas sample is without processing is probably 2 hours, even with covering with ice. You should shake it and you should homogenize it and remove the first 1 or 2 drops before processing. So this is the Allen's test, modified Allen's test, which I was talking about. There is an intrinsic mechanism in the body. If you are blocking the radial artery by thrombus, the ulnar artery takes over because there is an anastomosis in the deep palmar arch. Suppose there is some anatomical variation and this ulnar artery is not there, or the arch is not fully developed, the hand can go in for gangrene. So you need to make a fist, hold both the arteries, and make sure the hand is blanched, and release the ulnar artery, release the radial artery to see if the ulnar artery is patent. And the color should come back of the hand within 6 seconds. So if this happens, then you are safe in doing an ABG of the radial artery, especially a stab puncture. So this is how we should do an Allen's test. This is an indwelling arterial catheter, which most centers should be doing, and rather than doing a stab blood gas. Indwelling catheters, as I said, are the best processed samples because they ensure free flow. It can draw samples slowly. When we remove 4 times the dead space and inject back, even especially for an umbilical catheter, we should use a 2 ml syringe or less, but it needs some skill to maintain this indwelling catheters by using hep saline infusions throughout around the clock. Arterialized capillary is very convenient and simple, just making sure the heel is made warm by either using lukewarm water or steam towel. Avoid squeezing, and you all know where to prick the heel. Fill the drop from the tissue and rotate and mix the heparin. This, as I mentioned, avoid air bubbles because it can increase PO2 by 150. PCO2 can even go to 0. The information, some machines would ask you what is the hemoglobin of the patient, what is the temperature, what is the current FiO2. Some machines will not ask you. If there is an option, always put in this parameter so that the blood gas machine will give you the correct method of analysis. The anatomy of a blood gas has these many components. So can you tell me which of them are actually measured from the blood gas? In the chat box, I'm just looking at the chat box. There's not much activity so far. So which of them are actually measured parameters and which are derived parameters. Okay, while I wait for the answers, yes, you're right. pH, PO2, PCO2 are actually measured. Yes, lactate is also measured. The bicarb, base excess, SaO2 are not measured, they are derived. So we should be clear in which one to interpret. Right, so anion gap, bicarb gap, which are not measured in the machine. Right, so this is one of the ABG that usually you would see. Most of your machines will give you a sample report like this. And these are all calculated parameters. Even lactate, I'm sorry, is a calculated parameter. So a word about cord blood gas. Some of you may be in the habit of doing cord blood gas, but especially it's important if you are planning for therapeutic hypothermia. If you have a habit of doing for all deliveries also, it is desirable, but you should know what is the normal values. The umbilical artery pH is about 7.2 to 7.3. PO2 is very less. PCO2 can be considerably higher, 35 to 65. And bicarb and base excess can be a little low. The umbilical vein is closer to normal newborn pH, 7.35 to 45. PO2 is again low, but higher than the artery. And PCO2 is lower than the artery because it contains the oxygenated blood, which is from the mother. So this we should be knowing before we interpret any cord blood gas. Okay, so normal blood gas, as doctor has already told us, that it's about this. But having said that, the capillary blood gases may be slightly different. The PO2 can be slightly low, PCO2 can be slightly high. So we need to make that distinction. But do you need to have all normal parameters even for a preterm baby? The answer is no. So that concept is called the acceptable blood gas. We don't need to look out for a normal blood gas, especially in a sick baby or in a preterm baby. We need to know what is the condition of the baby. Let's say RDS, PPHN, BPD. Each condition has its own acceptable blood gas. So we cannot and we should not target a normal blood gas. That is message number 1 out of my talk. If you take, I would be happy. So if you do aggressive intervention just to make the pH 3.35 to 4.5, you would be causing harm to the baby. So one instance which I tell you, if the baby, like we had in case presentation, baby was less than 28 weeks gestation, you need to aim for a pH which is anyway more than 7.25. And PCO2 45 to 55 would be acceptable. PO2 would be acceptable even 40 to 60. So we don't need to do anything if the baby's blood gas is within this range. So that's called some concepts of permissive hypercapnia or permissive hypoxemia. Provided your pH is more than 7.5, you can accept a value of PCO2 which is up to 55 to even 60. It doesn't cause harm. If you try to aggressively normalize by reducing PCO2, it can cause harm to the baby. So again, babies with PPHN, we have now a baby with CDH, which we don't want the baby to have a normal blood gas like 7.35 to 4.5. We accept a slightly acidotic pH. Next, coming to the crux of this today's presentation, which is approach to ABG interpretation. So there are 6 steps, the rule of 6. The first is determine the pH status, which is the simplest of the steps. 2, you have to determine which is the primary process which is causing the problem. 3, you need to check if there is adequate compensation. 4, you need to look at the anion gap. 5, you can determine the oxygenation. Lastly, you need to correlate clinically. But I would say do the clinical correlation first before you do any blood gas. Okay, so that is step 0, that is clinical evaluation. Without clinical evaluation, you cannot interpret any blood gas. You need to know at least these many. So that's why when somebody puts up an ABG, if you don't know about the baby, you should not comment on the blood gas. You should know at least what the baby's symptoms are and how is the baby on ventilator, what is the current medication baby is getting. All of these can interfere with your blood gas analysis. So that's a caveat that you need to know about your baby before you venture into interpreting a blood gas which is posted. So this is the first OSCE or case scenario. Let's see how many of you get it right. A 1.2 kg baby on day 3 develops tachypnea. FiO2 requirement is quite high. There is some precordial activity similar to the baby which was presented today. ABG was done off O2, 7.27 pH, PO2 of 50, PCO2 of 42, bicarb of 14, base excess of -10, and saturation of 80%. Interpret the blood gas. Okay, it's not fair that I'm asking this question before, but I'm interested to know what your answers are. Okay, metabolic acidosis. Okay, so when you're learning blood gas, learn it in the stepwise fashion. That's why I told you rule of 6. Right, so I'm getting metabolic acidosis and mixed compensated acidosis as answers, which are true, but always go in stepwise. So pH is acidosis or acidemia, if you want to be totally correct. Second, what is the cause? Do you think PCO2 is the cause? 42, which seems normal. Bicarb is low, so it is metabolic acidosis. Third steps, which I told you, the fourth step was compensation. How do you check for compensation in metabolic acidosis? Is by using this formula. The expected PCO2 is 1.5 times the observed bicarb plus 8 plus or minus 2. In this, the bicarb is 14. So 1.5 times 14 plus 8 plus or minus 2 would be 29 plus or minus 2. This is the expected PCO2. But here the PCO2 is 42, which is above the range. So that means there is an additional component of respiratory acidosis. Why is this baby having respiratory acidosis? Probably because yes, precordial activity, day 3, I would be expecting PDA to have opened up in this child. So this is metabolic acidosis and respiratory acidosis. So it is much above compensation. It is not a compensated metabolic acidosis. It is a mixed acidosis, respiratory and metabolic acidosis. Oxygenation seems to be all right. 50 PO2 would be acceptable. So the anion gap, we will come to it when we have next blood gas where we have an electrolyte. So here we cannot comment about anion gap. So these are the steps which we need to go through. If you don't go through those steps and just say, see the pH and say, you will just say metabolic acidosis. You will not tend your attention to the respiratory component, which will definitely have an implication for management. That's why we need to do stepwise analysis, right? So this is the ABG report. It should not cause that. So back to basics. The pH we said was 7.35 to 7.45 is the normal range of pH. Second, you should know which is acidosis, which is alkalosis. Acidosis, anything less than 7.35, even 7.34 is acidosis. 7.45 and above, 46, 47 is also alkalosis. Right? So anything even in decimals, we accept as abnormal. What you should know about compensation is that respiratory compensation occurs fast. That is, once you have a metabolic acidosis, the body tries to breathe out carbon dioxide to get the pH back to normal. So, and that happens within 12 to 24 hours in the spontaneously breathing baby. That's like a leopard. Whereas metabolic compensation for a respiratory condition, if the baby has RDS, baby has pneumonia, the renal kidneys take long time to do that. So anything acute has to be compensated by respiratory system. If you have a chronic disorder, then only the kidneys will come into picture. The ultimate pH will be based on what is the capacity of the body and the lungs and kidneys. So normal neonatal ABG we have already discussed. We'll go stepwise. Okay, I'm coming stepwise. So I just asked that question to study or to tell you what is the focus of this next 10-15 minutes. You will know the 6 steps. First is pH. So you need not know that table. pH depends on what is the acid which is there. Right. So if the pH is 7.35 to 7.45 normal, PCO2 and bicarb we have already discussed. Bicarb compared to adult and children, we accept a lower bicarb even in term newborns. Anything less than 7.35 is acidosis. If it can be caused by two things. It can be caused by increased PCO2 more than 50 or reduced bicarb less than 80. So based on that, we will classify into respiratory or metabolic. If the pH is more than 7.35, it's called alkalosis. It can be caused by two mechanisms, one by less PCO2, less than 35, or higher bicarb more than 24. Quite simple so far. So I hope all of you are with me. Step 2, what is the primary disorder? Okay, so I need answers on the chat box. pH 7.23, PCO2 35, bicarb 14. What is the primary? These are all simple disorders. So what is the primary disorder here? For the first row. Yes, I'm getting answers. It is acidosis. Always first only look at pH. Determine is it acidosis or alkalosis? Acidosis. PCO2 35, can it cause low pH? No. So then you go to bicarb. Bicarb can explain the pH. So it is metabolic acidosis. You are right. Okay, go to second row. pH of 7.51, PCO2 40, bicarb 28. Answers. Don't say MA. MA can be metabolic alkalosis as well. Okay, so this is pH is alkalosis. PCO2 is 40, cannot explain the alkalosis. Bicarb is higher than normal, metabolic alkalosis. Okay, Bharti seems to think it's metabolic alkalosis. Sorry, respiratory. It is not because PCO2 is within the normal range. Next, go with the idea that is a simple disorder. pH of 7.13, PCO2 62, bicarb 21. What do you think this is? Quite simple. pH is low, so acidosis. PCO2 65 can explain this pH, so it is respiratory acidosis. Last, pH of 7.56, PCO2 of 30, bicarb of 22. Alkalosis, PCO2 is low, so it is respiratory alkalosis. Bicarb cannot explain this. So these are the 4 simple disorders that you need to remember. So if you have given close attention to the last 4 scenarios, whenever there is acidosis, the initial change is low bicarb. Compensation by the body is to remove the CO2. For an alkalosis, is high bicarb. Compensation is to retain CO2. Respiratory, the primary change is increased PCO2. The bicarb will try to increase to bring back the pH to normal. Alkalosis, the primary reason for respiratory alkalosis is washout of CO2, and compensation, which occurs much later, is by reducing CO2. Sorry, reducing bicarb. So far clear. Now we'll step up our complexity a little more. Let's go into third, which is a combined disorder. So look, this is the step 3. Okay, let's see how many of you get it right. pH of 7.1, PCO of 50, bicarb of 14. What do you think this is? Fastest fingers first. Respiratory alkalosis is not right. The pH, always look at pH first. It is acidosis. Can PCO2 of 50 explain this pH? Yes, PCO2 is higher, so it is respiratory acidosis. Now look at bicarb. Bicarb is also low. You would have expected bicarb to be higher or normal if there is respiratory acidosis. In this case, it is not. So there is both respiratory as well as metabolic acidosis. So this is a mixed acidosis. We will come to compensation next. Now, right now, don't worry about compensation. Next, the second question. 7.5 PCO of 30, bicarb of 28. Always look only at pH, alkalosis. PCO of 30 can explain the alkalosis, so it is respiratory alkalosis. Bicarb of 28 is also explanatory for high pH, so metabolic alkalosis. So mixed acidosis, mixed alkalosis. Always remember, two respiratory disorders cannot occur together. You can't have respiratory alkalosis with respiratory acidosis. Impossible. That means you have to breathe faster and slower at the same time. Cannot be done. But two metabolic disorders can occur, or respiratory and metabolic can occur together. So if you have a mixed acidosis, your pH will be low, bicarb will be high, and bicarb will be low and PCO2 will be high. Mixed alkalosis, high pH, PCO2 will be low, bicarb will be high. So far, so good. Next, you need to tell me, probably you can tell me, which is the predominant disorder. If we have a mixed acidosis, is respiratory component the predominant disorder, or bicarb component or metabolic component is the primary disorder? For that, you need to know how much is that parameter away from the norm. That is when you see the change in bicarb over normal bicarb, change in PCO2 over the normal CO2. Let's look at it with an example. Okay, answers for this also. 7.25 bicarb of 16, PCO2 of 60. What do you think this is? These are all part of OSCE. Acidosis. So step 1, acidosis. Step 2, PCO2 is high, so it's respiratory. Bicarb is low, it is acidosis. So it is mixed acidosis. There is no alkalosis in this at all. So it is mixed acidosis. So to know which is the predominant disorder, you need to know how much has the bicarb moved. Normal bicarb, if you take it as 24, the bicarb has moved by 8. That percentage is 0.33. Look at how much PCO2 has moved. If you take PCO2 normal as 40, it has moved by 20. 20 by 40 is 0.5. So can you tell me which is the predominant disorder? Yes, Surendra Murthy, you raised your hand. Do you have a question? Okay, you said respiratory acidosis. Yeah. So the predominant is respiratory because PCO2 has moved more compared to the bicarb, right? So it is mixed acidosis, but predominantly respiratory. That means you should look for a primary respiratory condition where you have maybe a pneumonia, which has caused both metabolic acidosis as well as respiratory acidosis. It happens most of the time. Okay. Now we'll go to your favorite, which is most misunderstood, which is compensation. Let's look at this. 7.3 pH, PCO2 50, bicarb of 28. What is the interpretation of this blood gas? I'll give you 2 seconds more than usual. Okay, pH is first rule, pH. pH is acidosis, right? Can bicarb explain the pH? Can PCO2 explain the pH? PCO2 is higher than normal. So there is respiratory acidosis. But what has happened to bicarb? Bicarb has increased, right? So what should normally happen if there is respiratory acidosis? Bicarb should increase. So there is a metabolic compensation as well. So there is respiratory acidosis with metabolic alkalosis. This is what has happened in this baby. Let's look at the second one. 7.5 pH, PCO2 50, bicarb 28. So 7.5 is alkalosis. PCO2, can it explain? No. So there is respiratory acidosis. Bicarb of high bicarb can explain higher pH. So there is metabolic component as well. So when I go to the next screen, you will be able to understand better. 7.3, again acidosis. PCO2 of 32 is alkalosis. Bicarb of 18 is metabolic alkalosis. 7.5 is alkalosis. PCO2 of 32 is low. It can cause alkalosis. 18 of bicarb can cause metabolic acidosis. So see, for the same bicarb and PCO2, you're having different pH. So for that, you need to know about alkalosis. So if I have to interpret the first blood gas, I will say respiratory acidosis, alkalosis with metabolic acidosis. Whether this is the result of compensation or not depends on the formula that you use, which is coming up in the next slide. So what is the clue for a compensation? In a metabolic acidosis, as we discussed in the first case, for expected PCO2 is 1.5 times bicarb plus 8 plus or minus 2. This is known as the Winter's formula. So you need to remember this formula. You can also remember just every 20 mm PCO2, but for me, it's difficult to remember. I just do this formula whenever I find metabolic acidosis. I will calculate the PCO2, which is expected. If my ABG is showing PCO2 within this expected range, I will say it is just due to compensation. There is no mixed disorder, right? So I hope I have made it clear. If it is not within this normal range, which is expected PCO2, that means there is an additional component, respiratory component, which may be adding to the primary disorder. So then it's a combined disorder. Similarly, you have another formula for metabolic alkalosis. So if you have diagnosed a metabolic alkalosis, the expected PCO2 is given by 0.7 into delta bicarb plus 40 plus or minus 2. If you do this, then you will get to know the expected PCO2. If it's within this range, that means it's just a compensation, nothing to worry about a respiratory disorder. For a respiratory acidosis and alkalosis, we don't have simple formulae like this. You have to remember the proportional change in bicarb and CO2. I think you would know all this is a common MCQ, which is asked in most of the entrance exam. That is, if bicarb increase for a respiratory acidosis, for every 10 mm Hg increase in PCO2, bicarb increases by 1 and 4 in acute and chronic. Because PCO2 happens in much higher scale, bicarb happens at much lower scale, 1 or 2 in acute, and for chronic, when it is kidneys are going kidneys can compensate better, then they change by 4. Respiratory alkalosis, which is acutely can happen, but again for acute compensation, it just reduces by 2, which is nothing much. For chronic, it can change by 5, but hardly never in newborn babies we'll find an alkalosis which is chronic respiratory alkalosis. Most of the respiratory alkalosis you find are acute alkalosis because you're over-ventilating the lungs. So no need to worry about this chronic alkalosis. Even for this chronic acidosis, very, very rarely do you get chronic respiratory acidosis without any underlying cause. So worry more about acute. Acute bicarb does not change much. It just changes 1 or 2 in respiratory problems. Only in metabolic problems, you need to remember this formula. But there are limits of compensation. PCO2, whatever is the pH, whatever is the bicarb, does not go beyond this range of 10 to 60 if it is compensation. If it is less than 10 or more than 6, definitely there is some respiratory cause additionally. It's not a simple disorder, it's a mixed disorder. Bicarb also does not go below 13 or above 35, whatever is the duration of respiratory problems. If you're not within this range, you are more likely to have a disorder which is mixed. Oh, I'll just recap so that I get your attention back. What have we learned so far? There are must-know rules. That is, the direction of pH will tell you whether it acidosis, alkalosis. Primary change and compensatory change always occur in the same direction. If you understood the examples which I showed you, if the primary change is increased PCO2, bicarb is the compensatory change that will also increase. So occur in the same direction. If there is opposite direction, that means always there is a secondary disorder. Body cannot fully compensate any acid-base disorder. So that's why mentioning compensatory respiratory acidosis, compensated alkalosis is a misnomer. It can tend towards compensation. It means always it is a partial compensation. It is never fully compensated. And compensation even does not overshoot beyond the limits which I showed you. If you find that compensation is inappropriately high or inappropriately low, that means you need to look for a second or a superimposed acid-base disorder. And acid-base disorder can come with normal pH. It does not matter if you have a normal pH, you can still have an acid-base disorder. That's why even if you have a normal pH here in this Sigurd-Anderson nomogram, you can still have compensated respiratory alkalosis and acidosis. Okay, now let's come to step number 4, which is calculating the anion gap. Anion gap is also a misnomer because there is no gap in the body. The gap exists when there is more anions and less cations. But there is nothing like more anions. They are always there equal. But the problem is we cannot measure these anions. We can measure all these cations, sodium, potassium, calcium, etc. But anions, you can measure only bicarb and chloride. We cannot measure this phosphate, lactate very well, proteins, phosphate, like that. So when you have a difference, it's an apparent difference between the cations and anion. That is called the anion gap. So gap between these unmeasured cations and unmeasured anions is the anion gap. What are these? These are in red. Unmeasured cations are low, unmeasured anions are high. That's why it's called the anion gap. So total unmeasured anions, if you roughly put a sum of all this, it would be about 23. Unmeasured cations, which normally we don't measure, calcium, magnesium, if you take only sodium, then it will be 11. So the difference between 11 and 23 would be 12. So the anion gap normally is about 12 milliequivalents per liter. Right? Why is it important to know the anion gap? So now I think you know how to calculate this anion gap. That is by using this formula. Sodium should equal to this. So the anion gap equals sodium minus of chloride plus bicarb. That is plus or minus 2 because we are not considering potassium. If the anion gap is more than 20, that means there must be an underlying acidosis regardless of pH or bicarb. Sometimes it can be the only indicator of a mixed, partially or compensated mixed acid-base disorder. That's why we should have an electrolyte along with the ABG for its complete interpretation, especially in metabolic disorders. And you know, there are different reasons for a normal anion gap acidosis and an increased anion gap acidosis. If there is normal anion gap acidosis, it means the bicarb is being lost from the body. There you will also get a high chloride, which is proportionately increased, like a GI loss, diarrhea, or a renal loss of bicarb, like renal tubular acidosis. But most acidosis which you see in newborn babies will have increased anion gap. That is because you have lactate or ketones or higher acids which are added to the system. We will not go into the delta bicarb or delta this one, yeah, right? So what we have learned so far is if pH is less than 7.4, it's acidosis. If it is due to a reduced bicarb, it is metabolic acidosis. So when you have a reduced bicarb, the compensation will be to reduce CO2 by the respiratory system, and you know the limits of that. Acidosis can also be caused by an increased CO2, where we call respiratory acidosis. And the compensation is by increased bicarb concentration in the blood. And you know the limits of compensation in acute and chronic. If pH is more than 7.4, I'm using that as a ballpark figure. It's called alkalosis. It can be caused by higher bicarb, in which case is metabolic alkalosis. And the compensation we expect is an increased CO2. And you know the limits of compensation. You can also use the formula for the same. If it is caused by low CO2, it's called the respiratory alkalosis, and the compensation is lower bicarb, and you know the formula for calculating the compensation. Lastly, the step 5 is to look at oxygenation. So to look at oxygenation, you know there is this oxygen hemoglobin dissociation curve, which sometimes can be shifted to left or right based on the parameters that you see. The parameters in blood gas, which is important for this oxygenation, is pH and PCO2. There is acidosis and low PCO2 is shifted to the left, acidosis and high PCO2 is shifted to the right. If it is alkalosis and low PCO2, it is shifted to the left. That means if shifted to the left, you have lesser release of oxygen into the tissues. So ABG can affect oxygenation as well. How to measure oxygenation is kind of a problem. Do you go by SpO2? Do you go by PO2? The better would be to use some indices like these arterial alveolar concentration gradient, which is called the AADO2. Normally, there should not be much gradient between the alveolar oxygen and the arterial oxygen, which you are measuring from the blood. Whatever is in the alveolar should get diffused quite easily. So there may be a very negligible difference of 5 to 15 mmHg. But if you calculate this by using this formula, FiO2 into 713 minus 1 and PCO2 minus PO2. This is based on the alveolar gas equation. If you get a higher ADO2, that means there is something intrinsically wrong with the lungs. It's not, alveolar oxygen is not getting diffused into the blood. By this, you can also derive something called the rule of 7. That is, for every 1% increase in FiO2, PO2 should increase if your lung, blood, everything is normal by 7 mmHg. If that is not happening, then there is something wrong with the diffusion across the alveolar capillary membrane. So there are 4 types of hypoxia. It can be due to less oxygen intake or ventilation perfusion mismatch that you get in lung disease. There can be shunting either intra parenchymal or outside the lungs, or it can be due to abnormal hemoglobins. Step 6 is probably anticipating a disorder in a given scenario. Okay, the chat box is again not very active. So let me ask you, in a perinatal asphyxia baby who is tachypneic, what disorder would you anticipate? Okay, Sujata says respiratory mixed, I'm getting respiratory, metabolic, mixed acidosis, metabolic acidosis. I'm asking you for the disorder, metabolic acidosis, yes. So asphyxia, all of you know, would be a metabolic acidosis condition. So you would get metabolic acidosis. Respiratory wise, baby is tachypneic. So baby is trying to remove CO2. So you will not get a mixed acidosis. You probably can get sometimes if baby is breathing too fast, you can get respiratory alkalosis. So primary disorder which you need to anticipate is metabolic acidosis. Okay, in a baby which was presented, if you get a lot of GI aspirate, you suspect pyloric stenosis. What could be the disorder in pyloric stenosis? A lot of GI aspirates you're getting. Even in NEC sometimes, where they leave their strictures, it can happen. Because of loss of bicarb, what you get is metabolic alkalosis, right? The baby is severely neurologically depressed. Baby is not able to breathe. Baby is retaining CO2. You will get, yes, Surinder, you are right. You get respiratory acidosis. Most of you have got this, right? Respiratory acidosis. If you overventilate a baby who is on ventilator for any reason, you get respiratory alkalosis, right? So you have to imagine. So I'll give you another scenario. So this is your next OSCE question. Neonate on day 5 had features suggestive of sepsis and shock requiring inotropes. ABG revealed this 7.22 pH, PO2 of 60, PCO2 of 21, bicarb of 8, base excess minus 16, and saturation of 87%. Interpret this blood gas. So go stepwise 1, 2, 3, 4, 5. Then tell me what is the complete diagnosis. Right? So first step is to see pH. Right? The pH is 7.22. That is acidosis. Right? That is the first step. Second, can this acidosis be explained by PCO2? PCO2, as I said, was 21, which is low. It cannot explain. Okay. Bicarb of 8, can it explain? Yes, it can explain. So what is the primary disorder? It is metabolic. So you get metabolic acidosis so far. Next, when you get a metabolic acidosis, look for respiratory compensation. Right? So when you have a metabolic acidosis, use the Winter's formula. That is 1.5 times the bicarb, 1.5 times 8 plus 8 plus or minus 2. Right? So 1.5 times 8 is 12. Let's say it is 20 plus or minus 2 is 20. So 18 to 22 would be the expected compensation. Here I see the PCO2 is 21, which is perfectly within this range. So is there a respiratory component? Answer is no. There is no respiratory component because it is within the compensatory range. So it is a simple acid-base disorder. Metabolic acidosis, partially compensated metabolic acidosis. It is understood that it is respiratory compensation is existing. So that doesn't mean it's a mixed disorder. So it is a simple acid-base disorder with adequate compensation. Like, okay. I hope it's clear so far. Case scenario number 3. Baby with congenital pneumonia on oxygen had worsening on day 3, for which requiring intubation ventilation. ABG done with the settings of 16.4, 16 by 4, 40 rates, 40% FiO2 revealed this. pH 7.46, PO2 of 63 by PCO2 of 36 by cup of 30, base excess of plus 4. That means there is plus positive and saturation of 90%. What is your interpretation? Okay, go stepwise. pH is alkalosis because it's more than 7.45. All of you got that right. PCO2 of 36. Can it explain pH? It's on the slightly lower side, but still within normal. Bicarb of 30, can it explain the alkalosis? Definitely can. So the primary disorder would be metabolic alkalosis. Right? Metabolic alkalosis, all of you are right. Now for a metabolic alkalosis, how do you calculate the compensation? That I showed you the formula, either by using this or by using the formula. Metabolic alkalosis 0.7 into change in bicarb plus 24 plus or minus 2. Or you can also use this proportionality, that is PCO2 will increase by 4 for every change in bicarb. So PCO2 should have been 44. I'll just show you the compensation formula again so that it's clear. We're looking at metabolic alkalosis and we're looking at formula for expected PCO2. So let me go back. Okay, so here is the formula. PCO2 is 0.7 bicarb minus 24 plus 40 plus or minus 2. So here the bicarb is 30 minus 24 is 6 plus 40. 0.7 into 6, 4.2 plus 40, 44 plus or minus 2 would be the expected PCO2, right? So the expected PCO2 would be around 44. But here the PCO2 was here the PCO2 is 36. So that means there is, Amit is right, he's saying mixed alkalosis. So there is a respiratory alkalosis, though the PCO2 is within normal range, right? Bicarb is quite clear because it's the primary disorder. So we have both respiratory and metabolic alkalosis. Case scenario number 4. A 2-month-old CLD baby comes back from KMC ward with respiratory distress, lethargy, reduced urine output, poor feeding. ABG revealed 7.52, PO2 of 54, PCO2 of 30, bicarb of 20, base excess +1, saturation 85. I have also given you the electrolytes, sodium, potassium, and chloride for a reason. So can you interpret this blood gas? So step 1, pH, alkalosis. So can PCO2 of 30 explain this? Yes. So there is respiratory alkalosis. What about bicarb of 20? In a respiratory alkalosis, you would expect the bicarb to be slightly low. It's probably adequate. So bicarb has gone down. It's a CLD baby, so we're dealing with a chronic condition. Chronic respiratory alkalosis probably set in. So the bicarb has gone down by 4 from 24 to 20. It's quite okay. So this is respiratory alkalosis caused by CLD. Okay, so don't go into that. It's a simple compensated respiratory alkalosis. Now calculate the anion gap. That's why I've given you the values. So anion gap is sodium minus chloride minus bicarb. So you get 27. So remember what I showed you. Whenever anion gap is more than 20, there has to be an additional component of metabolic acidosis. So there may be a component of metabolic acidosis which you need to suspect. Right. So abnormal collection we should always rule out. Yes, definitely. The dictum in ABG analysis are the pH, if they change, the pH and primary, if the change is in the same direction, it's a metabolic problem. So let's say pH is low, parameter that is bicarb is low, that means it's a metabolic problem. If pH and primary parameter are going in opposite direction, it's a respiratory problem. So pH is low and primary parameter PCO2 is high. That means it is a respiratory problem. You need not remember that. Pulmonary and compensation, as I said, take the pH towards normal, but very rarely to actual normality. A normal pH does not rule out a mixed acid-base disorder. So there are many calculators available, which you can just type in your all these parameters. It will give you even anion cap. And most of you should have these apps on your smartphones on your NHCM. So many of them are there and most of them are quite useful. But why should you remember is for the clinical correlation. So we all know that artificial intelligence is taking over, but we should not lose our brains in outsourcing our brains